Okay, so we are recording. I'm going to go ahead and go back to sharing my screen so that everybody has the instructions about what to do when they come in. So for folks who are coming in, if you wouldn't mind, please select a language channel, English and Spanish interpretation. We have today 2 language channels. And if you don't know where to find that, look at the bottom of your Zoom screen. You should see this little icon that looks like a globe, and that allows you to pick a channel. You do have to be on a channel. Even if you can hear me right now, you still have to pick the English channel if that's your native language. And also, as you're coming in whatever your native language is, please use the chat to tell us how you identify your role in the food system. And for folks who have been to many of these learning circles, you've done this many times before, but it's good to keep finding out who's in the room. And so your role in the food system could be your job title, or it could be eater, or it could be gardener. It could be however you define that for yourself. Welcome to see everyone, or at least everyone's names if I can't see you yet. And I'm just going to give folks another minute or so to trickle in. Also, if you wouldn't mind just muting yourself when you're not speaking, just to reduce background noise, that would be very helpful too. And I'll just keep repeating myself since you folks are coming in. So if you are new, if you're just coming in, please make sure to pick a language channel. You can see here, there's an interpretation icon at the bottom of your screen. You need to be on one or the other language channel in order to hear everything that's in the meeting, said in the meeting. And please also put your role in the food system in the chat, however you define that. And some folks are probably really used to doing that by now. And if you want, that role can change every month and you can give us a different answer every time. It's just whatever you feel like. All right. So I'm going to jump in here and I'll just make sure to keep reminding folks about the language channels, and please go keep putting your info in the chat. It's great to have the record of who is in the room. So this is the, I think, third learning circle of the emerging Hampshire County Food Policy Council. We've had learning circles on white supremacy in the Hampshire County food system, transforming white supremacy in the Hampshire County food system, as well as kind of looking at different food system assessment and planning efforts at different scales. That was in December. So for some of you, you may have participated in 2 of these already, and thanks for being here again. If you're new, thanks for being here for the first time. I'll give a little bit of context about what's going on here. So today's topic is bringing a trauma-informed lens to our food systems work. And in addition to me presenting just ever so briefly today, you will also be hearing from Chase Giroux and Rosie McMahon. Am I pronouncing that right, Rosie?
It's McMahon, but that's fine.
McMahon, okay, thank you. From Trauma Informed Hampshire County and their own organizations and work respectively as well. I'm just really excited to have these folks here today. I am also a member of the Trauma Informed Hampshire County Network, and I know that these folks and others have been working a really long time on this training, on what is called the Traveling Roadshow, I think. And I know a lot of effort has gone into it, so I'm really excited to be able to invite them here today to share it with all of you. And we also have Lori Loisel helping with tech support today. Thank you, Lori. And Catherine Bermudez is our interpreter, who I'm sure will get some work if we get any Spanish speakers showing up. So, and if you are, that's a good cue. If you are just getting here, please make sure to choose a language channel by clicking on the interpretation icon and choosing whatever your native language is, either English or Spanish, but you do need to choose one or the other. So just a quick agenda for today. I'm just welcoming folks right now. I'll do a land acknowledgement, and then I'm just going to pass it over to Chase and Rosie for the training, and then I'll wrap up. So let's start here with the land acknowledgement, and I'll just invite folks, since we're all in different places, to put your feet on the floor and feel whatever the particular land is beneath you. And I will read the land acknowledgement. You're welcome to read along on your own screen. So this is the land acknowledgement for contemporary Franklin, Hampshire, and Hampden counties. We want to acknowledge that we are benefiting from land that has been seized, expropriated, and stolen from Indigenous peoples. For thousands of years, this has been Pecumtuck land. This is still the homelands of the Pecumtuck, Norwottuck, Woronoko, Agawam, Nipmuc, and Abenaki. These native peoples and their descendants are still living here among us. Every time we gather here, we must acknowledge and respect that fact. Thank you. And if you have anything that you want to add to this land acknowledgement, please feel free to do so in the chat. If you have your own thoughts or feelings or words, it's always nice to share in these experiences of recognizing our history together. So please feel free to add anything you'd like. And just to give a quick, where this is coming from kind of thing. So this, for folks who haven't been to one of these yet, is part of the process of the emerging Hampshire County Food Policy Council. The Hampshire County Food Policy Council is funded by a grant through the Health Policy Commission, the Massachusetts Health Policy Commission, called the Mass Up Grant. It started off with a partnership between Cooley Dickinson Healthcare, us, I'm at Healthy Hampshire, the Collaborative for Educational Services. We're an initiative at the Collaborative focused on access to healthy food and opportunities for physical activity. And we are also working with a group actually that was called the Hampshire County Food Policy Council Governance Circle. We've now transitioned to a startup circle, and that group is sort of figuring out how to actually make this Food Policy Council happen. So we're really grateful for their role in that. That's a couple of different representatives from Amherst, Northampton, and the Hill Towns. And then we also partner with the Hilltown Community Health Center and Hilltown Community Development on this grant. And if you came to this session because somebody sent information about it to you and you have never been here before, or you know that you are probably not on our email list, please, please, please fill out our survey. I'll put the link in the chat. Here we go. So you can copy and paste that into your browser. If you haven't filled out the survey, you want to be on our email list, you want to keep updated as the Food Policy Council continues to emerge, please fill out the survey. It's the best way to help us stay in touch with you. And I think that's it. Yeah, that's the end of my presentation. So I will pass it over to Rosie and Chase. Thanks for being here, y'all.
Yeah, great. Thanks, Caitlin, and thank you for that beautiful opening and acknowledgement, the land acknowledgement. Really appreciated that. Lori, I'm going to invite you to move through a couple of the slides, probably to introduction, and just invite everyone as well. I think we already asked you to include your name, maybe the town where you live. If you haven't already, we would appreciate that. So welcome to our training today. So allow me to introduce myself as you're maybe adding to the chat your name as well. My name is Chase Giroux, and I am the Director of Community Education at Clinical and Support Options. And I'm part of the Trauma Informed Hampshire County Coalition, and I'm very grateful to be sharing space with everyone today. And I'm very passionate about this training, about this work around trauma for both personal and professional reasons. And I really appreciate Caitlin for creating space for us to be here as well. So allow me to tag my partner, Rosie, who I'm grateful to be sharing space with, and then Lori can say hello as well.
Thank you. Thank you, Chase. Does everybody know that this is being recorded? And if not, now you do. I just saw the recording and I was like, So I'm Rosie McMahon. And let's see, I identify as a white, cisgendered woman, mother, daughter, sister. And I also identify as a trauma survivor activist. And I've been living in the Valley for about 20 years. And I really love this community now. And I love all of the different groups and the different people who are interested in becoming more trauma informed. That means a lot to those of us in the group and to myself personally. Professionally, I wear two hats. I'm here as a consultant. I have a private practice called Optimistic Options, and I'm also a program manager for an AmeriCorps program that is based in Boston, but has satellite sites all over the state. So thank you. Thank you all for being here. And I'll just reiterate what Chase said, trauma-informed care, restorative justice practices, these are all lenses through which I do the work that I do. And yeah, it's just wonderful to be here with everybody. Back to you, Chase.
Yeah, Lori, you want to give a wave? Say hello?
Yeah, hi, I'm Laurie Loisel, Director of Outreach and Education for the Northwestern DA's office. And hopefully, if I do my job right, you won't know I'm here.
Thanks, Lori. We appreciate your support. So we're presenting this workshop, as mentioned, on behalf of a coalition called Trauma Informed Hampshire County, which is a broad network of organizations whose mission is to raise awareness about the impact of trauma and adversity on us as individuals, our families, and the community as a whole. And so we do encourage everyone to try to keep your cameras on if you can. I know Zoom fatigue and it can be a real challenge, but if you can, we would appreciate that. You will also be muted for much of the presentation, but we'll ask you to mute yourself when there's different exercises. Of course, if you have a question or reflection, feel free to just jump in and let us know. And we have the chat feature at the bottom of your screen too. If you want to share any reflections or questions, then we'll monitor that throughout our time together. I do want to offer a trigger warning because we're going to be talking about adversity in childhood and trauma. And as you'll learn, a very large percentage of people have this in their history, including people in this space. And so it's quite common for this content to stir up strong feelings. And so just really invite you to please take care of yourself. If you need to step away from the screen, talk to someone you trust after, just really using your skills to help calm yourself if anything arises. And when we look at the most challenging problems in any community, including ours, such as opioid addiction, homelessness, teen pregnancy, suicide, food insecurity, it's all a common thread. The common thread for all this is a history of trauma. And so when you look across the different sectors, such as schools and social services, police, fire, even private businesses, whether we realize it or not, we serve large percentages of people and have employees that are impacted by trauma as well. And so lastly, I just wanted to share that if you like this free training we're offering, and I think you will, you can certainly bring it to other organizations you're connected to, and we're going to give you the details about that later. Lori, if you move on to the next slide. And so I would invite you at this time just to put in the chat and complete these sentences. This presentation interested me because when I hear the word trauma, I think of. So if you could just put in the chat and complete those sentences. Love to hear your perspective. And this just gets some ideas flowing as we start the presentation as well. Right, so COVID is a trauma that is affecting us all. Any other responses? When I hear the word trauma, what do you think of?
You
Who's
can
just
say, yeah, you can say feelings, you can say events, you can say actions, you can say thoughts. They can be complete sentences, they can be phrases, words.
This presentation interested me because I want to see how you're doing with trauma understanding, trauma secrets. Appreciate that. Okay. Trauma, harm that comes from unwelcome intrusion. Yeah. Thank you for sharing. This presentation interested me because I think trauma impacts people in ways they may not be aware of, and raising awareness is the first step. Yeah, absolutely. Thank you. We'll just take another moment if there's any other thoughts or reflections. When I hear trauma, I take a deep breath and listen for everyone's trauma in the room. Yeah, so creating space for others as well. Thank you. All right, I'll keep looking and monitoring the chat, but I think at this point we could probably move to the next slide, Lori. And I'm gonna hand it back over to you, Rosie.
Before that, there was a second question there, though, just about when I hear the word trauma. And I would just love people to continue putting phrases, thoughts, words, feelings into the chat about just that word. You're here, you want to learn, and that's great. We're still learning. But when you hear the word trauma, what comes to mind? The first thing I thought of today, right at the start of the training, I had to cover my mouth because I sneezed, and I thought, oh, I'm so nervous about sneezing, even when I'm in a room by myself because of COVID. And COVID is this, large trauma affecting everybody all over the world. But trauma has been around before COVID. So what are some phrases, words, thoughts, feelings that come to mind? I think about the stigma and the difficulty in reaching out for help. When I hear the word trauma, my body freezes. I think of trauma-informed practice. Another one today for me, and it's related to COVID, is helplessness. So we assume when we do this training that there's no one here who hasn't been affected by trauma. So feel free to keep adding words and phrases. Feel free to ask questions in the chat. There's a few of us who are going to do our best to pay attention and respond quickly. All right. So as Chase said, I'm going to go over some definitions. And the first one I want to talk about is psychological trauma. And I want to begin by saying that there is a unique individual experience that everybody has in relationship to this word. And different people, even people in the same family, can experience the same events and have very different short and long-term reactions. An example that we like to give is you have two people driving in a car together. There's an accident. For one person, it feels very traumatic. And for the other, it's no big deal. And there's all sorts of factors that influence these different reactions that we have. And some of them include the age that it happened. I was in a car accident when I was a child. Our whole family, I remember that as a 6-year-old. And that's a very different experience. That's a very different memory, say, than the person who was driving, right? Who happened to be my mother. So other factors, the support systems that exist or not, any previous car accidents that a person might have had, our temperament, any other stressors in the person's life or family, the experience we have when we're talking about it. Is it honored? Is it dismissed? The severity of the injury, and so on. So psychological trauma is both the person's ability to integrate the experience and the actual experience that you have, physical, emotional harm, and or anything related to it being life-threatening. And that's where that word helplessness comes into play. Next slide. All right, so another word, we have psychological trauma, and then we have adversity. And I'll let you just take a few seconds to look at the definition that we have here. Difficult life circumstances, childhood adversity, when something happens in childhood. Sometimes these circumstances or events may or may not have been traumatic. So stress, I want to stress that adversity is generally more harmful when experienced in childhood. Usually the earlier the trauma, the more impactful. Some adverse events are not traumatic, depending on the situation and the person. And again, now, we had the car example, and I'll give the example of parental divorce. Sometimes that can be very traumatic with long-lasting impact or not. Next slide. So this word, resilience, in the field, we talk about resilience a lot. And that's really sort of where the scales tip in the other direction. That word is sometimes replaced with the word tenacity, sometimes the word grit. But essentially, resilience factors buffer the impact of adversity and trauma. And this is often described as the ability to bounce back from difficult events. And I think all of us know resilience, experience resilience, and rely on resilience. One of the most important resilience factors is the presence of a stable, caring relationship in one's life. And people who are able to thrive in spite of adversity and trauma often talk about a particular relationship, either with a school teacher, a coach, a neighbor, a friend's parent, that they connected with and supported them. So there is on one side trauma and adversity. We'll talk a little bit more about stress. And then on the other side, resiliency. Sort of how is it that we're able to make it to the other side and not just survive trauma, but thrive. Next slide. So we're going to be showing a video about stress. And I want to acknowledge that sometimes we talk about stress like it sort of doesn't belong, here in our life. But stress can be a very good thing. It motivates us and it helps us survive dangerous threats. So positive stress, we know we're having positive stress when we have brief increases in heart rate, mild elevations in stress hormone levels. If you all in the chat want to mention situations that are positively stressful, feel free to go ahead and do that. I'm going to move on and talk about tolerable. So imagine me explaining this as this sort of heat rising. You have sort of low heat, which is positive stress, and then you have medium heat, which is tolerable. And that's serious, but it's temporary, and it's buffered by supportive relationships. It can feel awful, but it is ultimately tolerable. And that can be like the death of a loved one, an illness, or an accident, if you have adequate support. And I want to emphasize that. And then the last one, toxic, which I call sort of high heat stress. We're going to talk, you're going to hear more about it. We're going to talk more about it because toxic stress is traumatic. And this is the prolonged activation of stress in the absence of protective relationships. So these are the three kinds of stress: positive, tolerable, and toxic, that we use when we're talking about trauma. And let's see, let's go on here. So we're going to show a video. It is very short. It's just 2.5 minutes long, and it's really powerful. And I want to ask, before I start it, that you think about this question. Does this remind you of anyone that you have known where many things, even small things, seem like a threat? Ta-Nehisi Coates, he's one of my favorite writers, and he's a well-known African-American writer who grew up in the inner city of Baltimore, surrounded by violence. He describes his childhood this way. Each day, 1/3 of my brain was concerned with who I was walking to school with, our precise number, the manner of our walk, the number of times I smiled, and who or what I smiled at. He says, I can hear my father telling me, walk like you have some place to be. Keep your head on a swivel. So that's the impact of toxic stress, especially without the buffer of resilient factors like caring relationships. Um, and we know that toxic stress can have a lasting effect. So I'm going to ask you, Caitlin, to play the video.
The reality is that we all need a certain amount of stress, a certain amount of anxiety to perform well. If we don't care about that exam that we're going to have tomorrow, we'll probably fail. If we're going to cross the street and a truck is coming at us, we have release of adrenaline. We have release of a hormone that we call cortisol. We want to jump out of there, and adrenaline and cortisol are going to help us do that. So there's that good amount of stress. But if all day long you're feeling like a truck is coming at you, day after day after day, that's going to take a toll on the body. And the amygdala obviously here has greater activation.
Yes.
In the PTSD. We were able to image children that had experienced trauma and compare those brain images with children that didn't have an experience of trauma and didn't have symptoms.
Right, an exaggerated fear response.
An exaggerated fear response. With decreased activation in areas that we need to control that emotion in the frontal areas.
Exposure to early adversity and trauma literally affects the structure and function of children's developing brains. So the kid next to them hits them, or the teacher reprimands them in a way that they're uncomfortable with, right? Literally what they're feeling, that activation is like there was a truck coming at them. You can give something that will mask symptoms, right? For example, if someone has a cough, right, you can give them a really strong cough serum that will suppress their cough. But if it's because they have tuberculosis or lung cancer, then what you're doing is merely masking the symptoms while the disease process continues to fester. We know what's happening in children's brains and bodies with the experience of toxic stress. So the question now is, what do we do about it?
Thank you. Thank you, Caitlin. Just want to take just a few minutes, and you can unmute yourself to respond. I don't know how many of you have even seen this video. Every time I see it, I'm so affected by seeing that little person try to navigate their surroundings. Anybody want to say anything in the chat or out loud?
I guess this has been coming up a little bit. I think one interesting idea you encounter is that we don't think of modern society as being more stressful than primitive societies, but I think some argument is being made that, I mean, the type of stressors might be less physical, but actually we are getting exposed to more stressors than we can handle. And even like things like social media and the constant email and chat notifications are stressors when you look at them. So we're kind of in these interesting times where we feel like we're physically safe, but our minds might still not feel like it's really safe.
Ah, that was, yeah, I'm just taking in what you're saying. I agree, sort of, one could look at sort of just stimulation, right, in the modern world as in and of itself being more stressful. And yeah, this notion that more is better may not actually be true for a lot of people. And so, thank you. Yeah, yeah. Yeah.
Well, and just the screens themselves actually looking at these screens changes our brains as well. So that can be problematic.
I can't see who's speaking.
It's Heather.
Oh, okay. Oh, thank you. Thank you.
Yep.
Yeah, no, there's a lot. And again, I just want to give a nod to COVID, you know, in terms of being part of everything that is going on in our life right now. So if things were hard, they are harder, right? Just because of COVID. So that's great, and people can keep responding either in the chat or unmute yourself, and we'll do our best to notice you. Chase is going to now review a lot of the data behind the trauma-informed care work that we do. Take it away, Chase.
Thanks, Rosie. Yeah, so we're going to talk in this next session about lifelong impact of trauma and adversity. And so it's the ACE study, Adverse Childhood Experiences. Could you all just give me a wave if you've heard of the ACE study? Perhaps many of us have. Yeah, so let me just share a little bit more. So ACEs was often described as the most important study that you never heard of, because for almost 20 years after it was published, no one knew about it. And this is now changing, and many more people are learning about the ACEs. And so I did want to share that, this can be upsetting information to listen to, since many of us have had this in our own history. And so we're not talking in theory about them, we're often talking about us. And so the good news again is that trauma and adversity are not destiny. Resilient factors counteract the impact of trauma. Lori, next slide, please. Okay, thank you. And so in the 1990s, a doctor at the California Health Maintenance Organization, Kaiser Permanente, kept noticing that women in his obesity program would lose large amounts of weight, but then gain it all back again, often very quickly, which had him suspect something else was going on. So he began asking them about their histories as children and found that at a very large percentage of them had been sexually abused. And what seemed like a solution to him, losing weight, actually posed problems for them. And he wondered if trauma in childhood was having a large impact on their health as adults. And so, curious about this connection, he teamed up with researchers at the CDC, at the Center for Disease Control. And they sent out a questionnaire to a huge sample of patients who were members of the California HMO. I do want to note, though, that this sample, it was a very mainstream, privileged portion of society. All of them were insured, middle income or above, and about 74% of that sample attended college. Next slide. And so in this questionnaire, they asked patients how many of 10 different types of adverse experiences, which are listed on the left side of the slide, happened to them in their childhood. So depending on the answers, the patients could get an ACE score of 0 to 10. So if you experience none, you got an ACE score of 0. If you experience 1, a score of 1, so on and so on. And so we're not going to discuss, but you might take a moment to kind of explore what your ACEs score would be. And it's important to note that some of these events may not be experienced as traumatic, like divorce and like what Rosie had suggested earlier. People have very individualized reactions to these kinds of events. So again, this doesn't reflect all the protective or resilience factors that people have in their lives. And we're going to discuss more of that too. The newest thinking and research about ACEs has expanded the ACE categories to include 5 more areas of adverse experiences, and those are listed in that box on the right. And so it's
Oh, wait, before you go, I just want to make sure that we let people really look at these. And in the ones that are listed on the right, it's not that those adverse childhood experiences weren't there before. It's that what I sort of call the science sort of catches up with reality, right? So we are now acknowledging things like racism, things like violence in a neighborhood, things like bullying have a huge impact on somebody. So I just want to make sure I give those things their proper.
Oh yeah, no, I was going to talk about that, but thanks,
I'm
Rosie.
sorry. Yeah.
No worries. You stole my thunder. Yeah, so it's very possible that the issues are as impactful, right? If not more impactful than some of the original 10 ACEs, like Rosie had mentioned. And so it's really important that they were added, as Rosie was suggesting, because many of them even solely or especially impact people of color. And so you can't talk about childhood adversity without recognizing that things like racism, right? Living in unsafe neighborhoods, witnessing violence are very stressful and often traumatic. And so efforts to address ACEs must go hand in hand with our work on equity and racial justice issues as well. Okay, Lori, next slide, please. And so when the researchers analyzed the responses from that questionnaire, they were really surprised, if not shocked, at the prevalence of adverse childhood experiences in this generally privileged sample of people. And so you'll notice in that graph that 36% had no ACEs at all, but 64% had at least one ACE, and 12.5%, so an eighth, had about 4 or more ACEs. And in about 25% of the households, there were substance abuse, and 25% of people said that they were physically abused. But I also want us to remember that this was a very privileged sample that we're looking at. Lori, next slide, please. And so, again, since they had their full medical records of these participants, they then looked to see whether there was a connection between the number of ACEs and negative health outcomes. And so first they looked at things that you might predict, like suicide, depression, and substance abuse. And what they found was that participants who had a higher number of ACEs also had higher rates of these negative outcomes. And that was stunning. However, was how that with each additional ACE, there were a higher rates of the problem. And this is very unusual in research to see such a close connection as you see that graph. So this is called the linear dose to response relationship because of how the bars go up in a line. And so if you just compared people with 0 ACEs to people with 4 or more ACEs, the people with 4 or more ACEs are 6 times more likely to attempt suicide. And they're 7 times more likely to have sex by age 15, and even 45 times more likely to use injected drugs. Lori, next slide. Thank you, Lori. So then they looked at other and more physical or medical negative health outcomes beyond the mental health and substance abuse issues. And these results stunned the researchers again, but even more. They found that, again, there was a close connection, and it also followed the same linear pattern as you see, those bars moving up. So the more ACEs, the higher percentage of people who had negative health outcomes. And so on this graph, it shows heart disease, lung disease, obesity, but we could easily show you slides for liver disease and cancer, diabetes, asthma, or anything else. And the pattern is exactly the same. It moves up. So this means repeated, unpredictable, and unanticipated stress like ACEs, it has a lifelong impact on mental and physical health. Trauma impacts people physiologically and on a cellular level. If you compare people with no ACEs, in 4 or more ACEs, people with 4 or more ACEs are twice as likely to have cancer, heart disease, and obesity. Next slide, please. And so this slide indicates it's related to our work settings. And so it's a similar graph related to job performance. So here, the more ACEs you have, the higher absenteeism, the more serious financial problems, and the more serious job problems. So ACEs are impacting our work lives as well. And this is what this graph demonstrates here. Thank you, Lori. So again, I just want us to remember that the original Kaiser sample, it was a very mainstream, relatively privileged group that they studied. This graph, it compares the original, which you see in blue, with a sample of girls in the juvenile justice system, and that's what we see in green. And as you can see, the juvenile justice girls have much higher ACEs. 12% of the original sample have 4 or more ACEs compared to 60% of the girls in juvenile justice. And so imagine the negative health outcomes for folks at higher risks in our community. Thanks, Lori. And so the thing that the ACE study doesn't talk about that is so important is resiliency. And so resiliency, it describes all the factors that strengthen well-being and helps people to endure the adversity and trauma. In research, it has identified a common set of factors that predispose children to positive outcomes in the face of significant adversity. So especially with the help of supportive relationships, people generally can overcome the impact of trauma. And even one positive relationship can have a huge impact on a child's life and their ability to integrate and handle trauma. So resiliency factors, a stable relationship, again, with a supportive person, feeling connected to a community, perhaps access to sources of faith, hope, and cultural traditions. Again, ACEs are not destiny. So, okay. And so the next slide, yep, thank you. And so we know from the ACE study that probably 6 out of 10 people in this space that we're sharing today have at least one ACE, and some may have more. So we want to leave you with some ideas about what to do if this applies to you. Even if you think it happened a long time ago, it doesn't matter because it can still impact us in ways we're not aware of. So acknowledging ACEs to yourself can help us take control of our health. Perhaps talking to a trusted person about this history is critical. So it's very common to feel shame about what happened to us, but letting others know how it can reduce the shame and it can hopefully lead to healing. And since a history of trauma impacts our bodies and can lead to what some are calling a trauma physiology, the real health problems, it can be really helpful to talk to your doctor or maybe other medical providers about your past. And this could impact how your doctor treats your health and works with you as a patient. And if you don't think your providers are sensitive to this or maybe know about it, perhaps you might urge your doctor to learn what a history of trauma can mean for taking care of your health. And a history of trauma, it can make it hard for us to manage strong emotions like fear, anxiety, anger, perhaps sadness. And these are skills we can learn to keep our emotions and our feelings perhaps even or more regulated. And since trauma can impact us on a cellular level, folks with high ACE scores, they need, and probably more than most people, to take special care of their body. So this means going to the doctor regularly, good nutrition, exercise, all the things that you're doing that we'll talk about later on to care, nurture our bodies. And finally, if you have children, perhaps you're thinking about how to prevent ACEs and trauma in your child's life. So even if they have ACEs current or in the past, reducing or preventing them now can make a difference. And so you do have the power to break the cycle of the ACEs. Okay, I think I'm tagging Rosie. If there's no thoughts, I see lots of chatting going on. Thank you.
Yeah, I mean, it's interesting every time I do this training and I hear that phrase about sort of, you know, trauma being on a cellular level. I like to think that healing can occur on a cellular level, and there's a lot of hope, and things don't have to remain as static as we might think. So that's to just draw your attention to what Caitlin said in the chat, thinking about the compounding effects of stress and then lack of access to healthy food in producing negative chronic disease outcomes. So it's this acute on chronic thing that can happen, which is what we're trying to draw attention to so as to remediate. So we're going to talk now a bit more about trauma-informed care, and we're going to begin the conversation by way of having you read, and I'll read it out loud, this scenario, and then I have a couple of questions. So the scenario: John is a man known for years for wandering the streets of town and has been frequenting a particular deli often lately. So this is all in real life, folks. So back to a time that we're not in right now, but we will someday return to. He comes in, buys a small cup of coffee, and sits at a table in the corner for hours. He sometimes takes off his shoes, and he has a pungent body odor and talks to himself constantly, often mumbling sexist comments under his breath. Yes, he doesn't harass anyone, but other customers keep their distance. The deli owner has asked him to leave several times, which he does, but he shows up again a couple of days later. So I have two questions for you about this scenario. The first one is, upon hearing me read it, what do you think most people's reactions would be? Not necessarily yours, but what would most people's reactions be if they were the deli owner? And you can, again, unmute yourself and speak, or you can answer in the chat. This is the non-didactic portion of the training here. That this person is driving away business. So there's an impact on his business, and it's not a good one. What about towards John? Sadly, I think a common response would be to ban him from the shop, think that this person is houseless, have him removed by the police, or even call upon the police. If I'm the owner, I would want this person to leave. I'm not interested in learning about this person's problems, right? You have other things to do, right? Frustration, possibly worry about the customer. He's not spending money, or he's not spending enough money. Being essentially super aware of his presence. Hard not to be, really, right? You don't just see him, you hear him, you smell him. You might be worried about his hygiene and the impact that has on you, and in a place that is, supposed to be clean. So these are all what we know would be essentially common reactions. And you've named some of what you think the deli owner would have to be doing or thinking about in response to him, right? So can I have this person here and still have a thriving business? Anything else anyone wants to add? This person needs support, possibly triggered personally based on past. Yeah, in a way, that scenario is interesting to me. Everything about it solicits compassion from my heart, except the phrase muttering sexist comments. And I have to do a little more work to feel compassion when that's going on, right? That might be true for others in the room here. And so, different things push different buttons in all of us. And sometimes we have to reach a little harder to feel compassion. Okay, let's go on now to the same scenario with some different information. John is a man known for years for wandering the streets of town and has been frequenting a particular deli often lately. He comes in, buys a small cup of coffee, and sits at a table in the corner for hours. He sometimes takes off his shoes, has a pungent body odor, and talks to himself constantly, often mumbling sexist comments under his breath. John used to hang out mostly at a fellow store owner's shop. That store owner told the owner of this deli that John has struggled with mental illness his entire life. After years of repeated hospitalizations, he now has permanent housing and a solid support team. Apparently, John has a case manager, and that case manager explained that John, a victim of serious sexual abuse as a child, learned that if he did not bathe, people would leave him alone and not hurt him. He is working on his hygiene. 3 weeks ago, the store owner where John used to hang out suddenly had to close his shop because his spouse is seriously ill. So John can no longer go there. All right. So we have some more information. So what do we notice would likely be different in terms of a response between the information in the same scenario, scenario two, and explain to me why the difference. Okay, so somebody's saying now maybe the deli owner could contact the support manager when possible. Wondering, how do I reach the support team? Understanding of community and community-based support. Willing to test tolerance-based. Willing to test tolerance-based on understanding. Willing to test tolerance-based on understanding. Okay. What else do we discover in terms of why John is behaving the way he is, and therefore what we might be able to do in response? Yeah, ability to have more compassion, add his gentle support to better hygiene, contact the case manager and reach out to customers in ways and places to help this person. Somebody just says, I so get John. Just converse with him, create connection, able to communicate in a language he may understand. He is living with trauma. He deserves dignity and support. So again, we're talking about most people. And for almost everybody, when you go from the first scenario to the second one about the same person, because you find out more, about this person's life, you're able to tap into more of your own compassion. So I want to stress that knowing something about the person, their struggles, their history, it always humanizes them to us. We can begin to understand that there are reasons that people do what they do, and it makes sense to us, and it leads us to have more empathy. Even if we don't know anything about the person's history, we can assume that adversity or trauma might, I would say, probably explains the behavior, right? And when you assume that the person has a backstory, because we all have backstories, you have more information, and that information is very, very helpful. So this is the difference between a trauma-informed approach and other approaches that people have tried, often approaches that are more punitive in nature. And we call this approach trauma-informed care, and it is the foundation of a trauma-informed community of which all of us are a part of. The next slide. And really, some things aren't this simple, but I think this is pretty simple. It's reframing our response to challenging behavior from what's wrong with you to what has happened to you. A what's wrong with you stance views John as a crazy mental health case that is othered, a nuisance that is making my life harder and needs to know the consequences if he is going to continue his behavior. A what happens to you approach assumes that John is doing the best he can. I'm going to repeat that. Doing the best he can, and that his behavior makes sense given what has happened to him. And that maybe if I get to know his story, I can work something out. And that would be true, I think, either of the customers or the deli owner, right? You know, what can we do for somebody? That's a big question. And we believe, those of us in the Trauma Informed Health Network, that, you know, thinking about what has happened to somebody as contributing to why they're behaving makes it that we can do more to be helpful. Any comments or questions about what I'm saying? I'm not able to keep track of talking and reading the chat as well as I thought I could. All right, so trauma-informed care. So we talk actually about the 3 E's of trauma-informed care: the event, the experience, and the effects. And then there's the 4 R's. Okay, sometimes mnemonics work for people. So trauma-informed care started as a new approach to treatment in the mental health sector. I don't know when it started. It's been around a long time, and I've been aware of it for a while. But now the philosophy has spread to many other sectors like schools, police, first responders, the legal system, hospital care, and even whole communities, such as this one. And that's why we, Chase, Lori, Caitlin, and myself, are part of the Trauma-Informed Hampshire County Network. So this is the definition of trauma-informed care. It's a philosophy, an approach where all parts of a community realize the impact of ACEs, recognize the signs, respond by applying the principles, and resist re-traumatization, which is often sometimes another way that people get injured. And re-traumatization is what happens when many institutions in the community unknowingly conduct themselves in ways that make things worse for the trauma survivors. Does anybody have any examples that they want to share about re-traumatization, either from your own work, from your own life? I think we saw a lot of it in the news this past year. And thank you, everyone, for asking what the letters mean and the acronyms that we use. Sometimes those of us in the field, we get so used to using all these letters. So I'm really glad folks are asking and then other folks are responding. But any other examples of re-traumatization that you can think of?
Well, we actually had one in our food work at Meadowbrook. We had a woman who was a refugee, and she has really, really dark skin, and she would usually send other people to pick up her food at the mobile market. And on the day that the Gazette photographer was there, she was there, and she ended up being the lead photo, and she looked really disheveled in the picture, and she was the lead photo, and other members of her immigrant community were distressed that she wasn't sort of dressed well, because that's part of the culture. And she doesn't live in my apartment complex anymore. She ended up becoming even more reclusive and more sort of re-traumatized from the things that brought her to this country in the first place. And any one of us, had we spoken up to that Gazette reporter, could have prevented that problem, and none of us did.
Yeah, I was just going to ask you, like, what could have been different? And so you answered the question, right?
Yeah, basically what could have been different is we could have gone, oh, that's like virtue signaling. And also she wasn't necessarily representative of the majority of people who live in my complex and who came, and there were a lot of other pictures of people. But this was the one that was like, oh, there's all these white people helping a black person. It's
yeah, you have to wonder why that photo, for sure.
You know, we could have done a really beautiful photo that was somebody from the community receiving assistance.
Yeah.
and not done this to this person. Like this was the one and only, I think it was the only time actually that she personally came. My information is that she sent somebody most of the time.
Yeah.
So she finally ventures out of her house, and in her culture, she's Somali, and they dress up when they think they're presenting a public face.
Yeah,
So
no,
here she was.
your point is well taken, and I have to move us along, but I think, and I
Sorry.
think it's a great real example, right? And I think for those of us who are trying to help and we're in helping situations, we want, we don't want to hurt people again, but it can happen, and sometimes unwittingly, and sometimes because other people who maybe could take more risk don't step in. I think that's another implication in what you're sharing. In the chat, people mentioned police intimidation. I mean, I would go further to say police brutality, racialized microaggressions. There's all different ways people can get re-traumatized. And I think the more you think about this in the work you do and in the lives that you live, the more you're going to see moments where we need to be more gentle and more understanding. I'm going to pass this on to you now, Chase, the next section of the
Yeah.
training.
Thanks, Rosie. Yeah, so we talked about trauma-informed care, and now we're going to move to how does it apply to everyone in this space. And so using a trauma-informed lens impacts everyone in the community. And so the ACEs research shows just how many of us have experiences of childhood adversity and trauma. So whether we know it or not, we are interacting with people impacted all the time in our personal and professional lives. And so it impacts all sectors of our community. So we want to discuss what all sectors of the community can do to make our communities more healing and less re-traumatizing. So on this slide is a list of different sectors. And so I invite you, if you can think of any other community groups that you think would benefit from a trauma-informed lens impact. And if you have any other suggestions, please write it in the chat. So far we have the city, county government, first responders, schools, mental health providers, medical providers, business owners, faith-based housing, youth. I'm just curious if there's others that you can think of. And I think just for time, I am going to move us along, but I would just continue to share in the chat if there's any other groups that you can think of. And so we're going to do an exercise in just a moment, exploring things people can do in their various roles. But here are two important things we can do to start with. First, foster connection and healing relationships. And second, prevent the re-traumatization. And so while many people can feel hurt in relationships, it's also where the healing lies as well. And so connection and relationships can be healing, whether it's maybe a one-time relationship or over a long period of time. And so if you've ever taken a child, perhaps, to the emergency room in a crisis, you probably recall whether you were treated with kindness, maybe empathy, respect, as opposed to harshness, maybe being dismissed with impatience. And so people that have experienced trauma, they have a template of what they expect in relationships. They expect to be betrayed, maybe punished, left. And healing connections, it contradicts those basic expectations, and it can really help people form new templates. And trauma, it breeds isolation and feelings of unworthiness. And so often they're left thinking or saying, I can't talk about this. If people knew, they'd want nothing to do with me. I'm unlovable. In healing relationships, it invites people out of their isolation, building a sense of belonging and show that they're worthy. And there's brain science that's now showing that healing relationships actually rewire the brain. And so a brain after counseling, for example, it often looks different than at the beginning. And so we can see ourselves as brain surgeons without a scalpel. Okay. All right. So the second, preventing re-traumatization. So again, our actions, without even realizing it, it can make things worse for people that have suffered trauma. And so people who have been hurt sometimes react by doing things that stir up strong feelings in others. And so they can unknowingly invite shame, maybe blame, a punitive response. And so we can work to resist that impulse and remember that they're doing the best they can in that moment, that they're doing the best they can. And we can remember to ask ourselves, what happened to this person and not what's wrong with this person. And so extreme behaviors were and they are survival skills. They're reasonable adaptations to a damaged world. And so remember John that Rosie had introduced to us in that exercise, whose bad hygiene worked to keep people from sexually abusing him more. And so here we have a quote from Viktor Frankl. He's a death camp survivor from World War II. It says, an abnormal reaction to an abnormal situation is normal behavior. Just take that in for a moment. Okay. Thanks, Lori. So here are trauma's impact on individual survivors. And so looking at the individual level, this slide contrasts the impact of a safe world versus a dangerous world. And so on the left, you'll see people with low ACEs. We have a tendency to see that they're in better control, right? They feel in control of their lives. They respect, yet can also challenge people with power. They expect to be treated well and life generally works out. They feel worthy and likable. However, people with higher ACEs tend to feel lack of control, have extreme reactions to people with power, be on high alert, right? Constantly scanning their environment, be highly prone to feeling unworthy and ashamed, be easily set off by triggers, right? That relate to their trauma. And so we're going to talk about these impacts in this next exercise. All right. So what makes things worse? What makes things better? Lori, could you move to the next slide, please? Great. All right. I'm actually just going to take a moment. I'm going to grab the link and put it in the chat for us to this worksheet. And you can pull it up. So in just a moment, we're going to move into breakout rooms. So Caitlin's going to move us into breakout rooms for the next 7 minutes or so. And what we're going to do is we're going to ask you in your smaller groups to explore these questions. So on this worksheet, you see on that first column, examples of impact of trauma. So people with histories of ACEs and trauma often, they don't trust and they expect to be hurt, have extreme reactions to authority figures, and they fear and expect the worst. And so what we're inviting the conversation when you get into your smaller groups is, what are some practices in your setting, in your role, that might unwittingly, right, not on purpose, make this impact worse? And what are some practices in your setting or role that could intentionally make this impact better? And so there'll probably be a handful of different groups. I would invite like the first 1 to 3 breakout rooms. If you could start from that first row of do not trust and work your way down. And probably groups 3 and 4, start from the fear and expect and work your way up. Because after we get into our back to this main room, we're going to discuss this as a larger group as well. So I'd invite maybe someone could take notes or sort of recall different things that come up in your smaller groups. Caitlin,
I think having a person who's willing to report out to the group would be great. I also want to remind people that you want to give space for everybody to contribute. So if you tend to talk a lot, talk a little bit less. If you talk a little bit less, maybe talk a little bit more. Share the space. Share the space.
Yeah, the 7 minutes will go by quickly. If you're not familiar with the breakout rooms, you'll may see something that you have to click, and you'll go into your room, and then you'll see a timer that will give you a countdown typically for the last minute, so you know you'll be returning back into the space. When you do return back into the main room, if you can just make sure that you put yourself on mute again, just to eliminate any background noise, because it can get kind of loud on the transition. Does anybody have any questions before we transition into the rooms?
I just have a question for you, Chase,
Yeah.
Rosie, and Lori. Do you all want to be in breakout rooms?
No.
You can leave us here in the main room.
I mean, I would love to, but I'm going to check in with Lori and Chase. But thank you.
Thanks, Caitlin. All right, everyone, welcome back. Welcome back. Okay, so I am mindful of the time, but I do, we'd love to spend a few minutes to kind of share some of your reflections in your smaller groups. Caitlin, how many groups were there actually?
4.
There are 4. Okay, great. So I would love, we'll just, if we could have anyone, feel free to unmute yourself if you prefer to just put any reflections in the chat. For that first row, do not trust and expect to be hurt or betrayed in relationships. When we see this as a response of trauma, what are some things that might make this impact worse? What did folks come up with? Again, if you just want to mute yourself and share, if you want to put something in the chat, what'd you come up with in your smaller groups? I'm just assuming everyone's typing right now. All your wonderful responses and reflections. Yeah, Andy.
I just want to verbalize some of this. I was in a group where we focused mainly on what we could do.
Yeah,
so
sure.
I'll infer what would make it worse.
That's great.
Using religious authority. So religious, church people trying to be helpful, if it's said or done in a certain way, could be hurtful. Also, not following through and doing what you said you were going to do, or having boundaries that are unclear, can make it worse.
Yeah, so I can appreciate how, right, if you're aware of your boundaries, then not having boundaries, right, would make things unwittingly worse. Thank you so much. I'm just looking in the chat as well. Someone posted all their notes. Is that what happened here?
All right, they're gonna get a good score.
I tried to share our notes, but it looks like Kia, there's I haven't gotten the privacy setting right. So
oh yeah, it's a Google Doc. Okay.
Points for trying.
But I can share a couple of things we talked about, and then maybe others can jump in. We talked a little bit about people feeling like they're not being heard when we're working with them, and that can exacerbate the way, sort of re-traumatizing people, feeling like people don't feel like they can trust us, and that it takes time to build trust and develop trust. And we have to kind of be committed to that process over time. We talked about when there are unclear expectations, people might not feel like they know what to expect or don't feel in control, and that can make people feel worse in the moment. And then we kind of talked about the flip side of what we can do.
Yeah, and I see that could be really across all 3 of them of what you discussed. So I appreciate those reflections, and looking forward to hopefully we can get into those notes and dive a little bit deeper at some point too. I am very mindful of the time, want to create space for the rest of our time here. If there's any other reflections, please share in the chat. Would love to hear what those were, and really appreciate you moving into smaller groups and unpacking that a little bit more. Lori, if you could just move to the next slide. Thanks so much. All right, so now we're going to talk about becoming a trauma-informed community. So next we're going to briefly talk about examples of practices that different sectors of our community could implement to become more trauma-informed. And so these are examples we're about to look at, and they're just a few of the many that communities are enacting. So they address both the adverse child experiences, and that's what you see above the ground in that on that slide, and the adverse community environments of what we see below the ground, more of the root causes like poverty, violence, poor housing, community disruption. Next slide, please.
All right, so now, now we're going to, go from these concepts to the practical world that we all live in. So, some of these sectors you might interact with or you have interacted with either in your personal or your professional life. And it's sort of a question with answers. And the time that we have at the end of our whole time together, we're going to explore, what all these questions mean in regards to the work around food insecurity. So the first question is, what can schools do? And these are just some of the things: revise suspension and expulsion policies, train staff that problem behavior is often a perfect adaptation to a damaged world, teach social and emotional skills, train support staff about the critical importance of relationships. And then what else? And we'll ask that question for all of us to consider the answer to. Next slide.
Great. Thank you. And I'm noticing people are putting their reflections in the chat. Thank you. I see you. So what can first responders do? Counter the perception that you're an authority figure, right? That will hurt them. Calm the environment before intervening. Provide choices, options when possible, and validate concerns and feelings. Validation does not mean agreement or that we're not setting limits. And just consider what else.
All right, next slide. What can physical health providers do? PCPs. Screen routinely for childhood adversity and trauma. This is something they're doing in California. We want them to do it here in Massachusetts. Ask permission and provide choices when possible. Recognize that you are an authority figure, so explicitly invite feedback to level the power difference. Inquire about simple accommodations that could make medical exams more tolerable. This is a whole conversation that we're hoping to have with different medical providers in this community. What else?
Great, thank you. And what can government do? Train staff about trauma-informed care. Review their forms for questions that are potentially shaming, and post information that is welcoming and not just about rules and limits. And let's consider what else.
What can veteran providers do? Provide peer-to-peer mentoring. Recognize the reality of military sexual trauma. Address and coordinate care. What else?
Great. And so what can business owners do? Similar to the exercise we saw with John. Post information that's welcoming, not only about rules. We see that these intersect across many of the communities. Be open to the possibility of accommodations for customers with special needs. Don't only think about consequences. Understand that odd behaviors may be the perfect adaptations to a damaged world. And set limits in a compassionate manner. Let's consider what else we can do.
What can mental health providers do? Yes, even mental health providers are not always trauma informed. Recognize that trauma and childhood adversity is at the root of many mental health diagnoses. I would add alcohol and drug addiction too. Screen for history of trauma and recognize that disclosure of trauma is a process. View symptoms and problem behaviors as adaptations, and use the power of the relationship, the therapeutic relationship, to heal. What else?
Okay, last but not least, we have what can civic organizations do? Raise community awareness about ACEs and their impact. Advocate for more compassionate community. Fund organizations that are building resilience in community members. And again, what else?
Very good. And I just want to call out, Andy made a note in the chat, curious about how this insight in trauma-informed care relates to self-organizing groups and how they govern themselves, especially when emotions bubble up in the group. And then somebody else, I think, had a sort of connected question about faith groups and religious groups. So anyway, there's more introspection that needs to happen and more ways than we can think of to integrate trauma-informed care. All right. Last but definitely not least, sustaining ourselves, moving from compassion fatigue to compassion satisfaction. And I have to say that when I first got exposed to trauma-informed care, one of the things that appealed to me is the emphasis and the focus on sustaining ourselves, which is often not only something that's overlooked, but people, essentially get rewards for working too hard, too much, too often. So I assume, and Chase and I assume, that many people here are caregivers in one way or another, either in your personal or your professional life, paid or unpaid. And if we are, we're at risk of what's called compassion fatigue. If you care about the world, just watching the news, I'm saying this slowly because of this whole past year, can lead to compassion fatigue. And this definition reads emotional and physical exhaustion that can affect helping professionals, caregivers, and concerned citizens over time. And if you work directly with trauma survivors in any way, you're even more prone to this experience. In general, our goal is to move from feeling mostly compassion fatigue to mostly compassion satisfaction. Compassion satisfaction, the satisfaction that you derive from being able to do the good work of being a helper, a carer, a helping professional, a caregiver, a concerned citizen of this community. A critical challenge for all of us is how to keep our hearts open to suffering in a way that helps us grow as people and feel some measure of reward and hope, as opposed to getting mired in helplessness and cynicism. And again, I just think all of us, between COVID and Black Lives Matter and politics and winter weather, there's just a lot to drag us down. But the goal is to stay well. The goal is to keep our hearts open. So we need to pay attention to compassion fatigue, and it reveals itself in three distinct ways. Physically, and I named some of those already, fatigue, exhaustion, and that also includes susceptibility to illness. Behavioral, irritability, an increase in drinking and drugging, not attending to our family, being overly responsible, labeling people, and becoming isolated. And then psychologically, cynicism, feeling bad about yourself, you're not doing enough, an inability to feel empathy, that's often a sign of burnout, problems with intimacy and concerns about safety and trust, along with intrusive imagery. And again, I was thinking back to what Nathan said earlier about the world that we live in right now, where we have to make a conscious choice to turn off the imagery, to turn off the stimulation that we're always getting, auditory, visual. And if we don't, we end up consuming too much of the negative, and then it becomes really hard to manage. So we need to anticipate, next slide, anticipate and prevent the signs of compassion fatigue. So for anything, first step is awareness. You want to be attuned to your own needs. You want to heed all sources of information. I mean, a lot of people, you carry your stress in a certain place in your body. In my body, it's in my knees. In some people's bodies, it's in their neck. We know ourselves, and practice mindfulness and acceptance and not being judgmental towards ourselves. Then B, balance in our work, in our play, and in our rest. Just think of it like a mathematical equation. Are we working too much, playing too much, resting too much? And then the last one, C, for connection. Connection to ourselves, to each other, and to something larger. All right, so what I'd like to do now is have you brainstorm with us, as you've been doing in the chat. What kind of things do you all do right now to address compassion fatigue when you're feeling it? Another way of asking that is, what do you do to take care of yourself, to nurture yourself, and to give yourself a break from life when it's too hard? And try, everybody, to give one suggestion. Okay, practice and teach mindfulness. Mindfulness, living my own values. Qigong, yoga, and walking, spending time alone, contemplative, introspective walking and hiking, maybe sometimes with a friend, listen to music. Yoga gets named again, hiking. Don't we live in a great place? Self-forgiveness, walking with friends, baths, prayer, yoga nidra, reading a novel. Self-forgiveness. Did I say that one already? That bears repeating. Yoga, dancing and laughing. Dancing, morning ritual, just having rituals that you adhere to, making tea and then taking a quick walk. How often, we can get distracted from the very routines that will actually sustain us. Cooking a nice meal, again, hiking in the woods, go out there and take your forest bath. It's awesome. Greet a tree, another living creature that has a lot of wisdom. Yeah, anything we can do to nourish ourselves. I don't want to leave anybody out. These are awesome. I just feel better reading them, reminding ourselves that we need to take care of ourselves. Oops, hit the wrong button. Oh, cuddle with our animals, right? Everybody got a puppy. Not everybody, but so many people got puppies, in part, right? All right, so we could go on and on. I think it's really important to prioritize compassion, satisfaction, and it is for everybody, but especially for people who tend to be givers. And we really need to be mindful of this, and we need to be aware of the toll that giving can take if we don't give ourselves the experience of self-love. Why don't you go on to the next slide here? Trying to move through all this. So caregiving doesn't have to deplete us. It can be uplifting, rewarding, and help us grow as people. Focusing again on compassion, satisfaction. Witnessing and attending to suffering teaches us about courage and human resilience, gratitude for our own lives. I don't think anybody mentioned in the chat the sort of practice of thankfulness and gratitude, which has been studied and is known to be a way to just feel better about your life, no matter what's going on. There's usually something to be grateful for. The power of hope, the importance of making meaning out of suffering. And does anybody want to add anything else about compassion? Oh, I'll just read this one out loud. Being with people in trauma when it releases into joy is the best. All right. We're doing great on time, Chase. I'm very proud of ourselves. I'll give you a little pat on the back there. All right, so we're going to do a summary here, but we're not done. We have 20 minutes so we can talk with you all about the specific work that you do. But we're going to summarize where we got to so far in our slides.
Great. Thanks, Rosie. Thanks for guiding us through that conversation. And thanks, everyone, for sharing your beautiful reflections and the way that you care and nurture yourselves, which is just so important. So allow me to just summarize our time together and what we discussed and hopefully learned today. So in summary, we talked about childhood adversity and trauma that are very common in our communities, and they can have a lifelong impact on our health, mental and physical. Resilience counteracts the impact of trauma. The impact of ACEs is predictable. What's predictable is preventable. A trauma-informed community asks, what happened to you, not what's wrong with you, like our friend John. Professionals and community members can take actions to heal the impact of trauma. Compassion fatigue is common and must be addressed. Compassion satisfaction is the goal. And a trauma-informed Hampshire County builds resilience and hope. So I just want to stress that a trauma-informed community, right, it's healthier for all of us. It fosters hope, it builds resilience. And again, just want to thank you for sharing space with us today, for taking part in this very, very important work. So here, if this, if this training, if you found value in it and want to continue to do your work, perhaps sharing this and bringing this training to other organizations, and you can do so by contacting Ruth, and here is her email, Hampshire TIHC@gmail.com. I also put an evaluation in the chat. Your feedback is really valuable, so would love to get your feedback. Really be as honest as possible. That will help inform our training if we need to make any changes and shifts. So what I would invite us now is, if you want to just click on that evaluation, just bring it up in your browser, and then you can go back to it after we move into a further discussion as well. So Laura, you could probably stop sharing. Oh, there you go. You knew. You got
There
this.
you go. You guys get telepathy now. Yeah, right.
I did see a question in the chat about whether the presentation will be sent to participants. What is your protocol with that?
Do you know, Chase? I could pretend. I don't know. Lori, do we?
So what I can say is,
No.
I heard Ruth the last time say that we haven't shared the presentation yet. We can take it back to the network and say that, people are wanting this, and we'll circle back around to you, Caitlin.
Okay.
That's the best I can say right now. But yes, we definitely want to share this information. So just allow me to circle back around. Yeah. Okay. So who wants to get us started in guiding us in the last, we have 20 minutes. That's beautiful. We have 20 more minutes together.
I think, Caitlin, you were going to frame it a little bit, right? In terms of what you're thinking the group is interested in and how we might be helpful.
Yeah, so I think what we talked about, and Heather and I talked about this too. So Heather, I invite you to jump in. But you had all those slides that said what can certain sectors do, and I think we talked about maybe kind of imagining that as the heading for the slide. So what can food system advocates do? And so you might answer that from your particular role or positionality that you come at this work, come to this work with, or you might think more broadly about other folks or roles in our community. Heather, did you want to add anything to that?
Well, the only thing that I would add is sort of, it's important if I'm doing work to understand what my own trauma and biases are, because that way I won't sort of reenact something on somebody, and just knowing how delicate and easy it is to shame somebody about food or to disregard their culture, and I think cross-cultural and systemic understanding and understanding where we're coming from ourselves is the biggest part of food work, because food is huge. I mean, being traumatized actually affects how your body works. It won't work around food the same way as it does, even if the food wasn't part of the trauma. So this goes right back to what our bodies experience, and it's really delicate because that food touches every single level of how trauma works. So.
Thank you.
Yeah, Heather, and I'm thinking about how I've heard you talk about people sort of using food as a comfort response to trauma as well. And, we all really, all of us here probably really want to advocate for, people getting as much healthy food as possible and not necessarily anticipating the negative consequences that those dietary changes might have for folks.
Right, and they're temporarily negative, but if you don't understand that, you need to support them. So the two things that I know biologically is that if you are traumatized, for example, by being hit as a kid, one of the ways your brain responds is that the leptin cycle that tells you that you've had enough food shuts off. So then that's like had it set up for an eating disorder that people get then re-traumatized and shamed about. And the other thing about it is a high level of glucose or sugar in your body will actually prevent an immediate sort of bodily sensation of flashback. And it can also prevent memories from surfacing. So if you stop eating sugar, and you start eating vegetables. Oh, and the enzymes in your body aren't the same if you've been eating sort of a lot of processed food and not a lot of vegetables or things like that. So the minute that, and this happened in our complex, we had somebody who was worried about the mobile market, and it took several texts each week to have her come and get her food. And she started to eat more healthily and started having flashbacks and started reenacting on people. And we needed to, some of the residents where I live needed to help her get to therapy. So she needed a massive amount of support to even get to the mobile market. And then she needed a massive amount of support to get to therapy. And there have been some really big changes in her life, but it was drastic and dangerous for her and for some people around her. So if you don't know that, if you don't know that's even a possibility, it's easy to misstep, you know, and the other thing that I like is the sort of harm reduction approach. Like, instead of eating Doritos and Diet Coke for dinner, Heather, maybe you want to eat a burger. Now, maybe the burger isn't the best thing. Maybe it's not a salad, but it's not Doritos and Diet Coke. So knowing how you're going to help people inside their culture and inside their own situation can be a big deal.
Yeah, I like that, Heather. There is a relationship between trauma-informed care and harm reduction. And I am thinking about trying to do a training on the way those two things are connected. And as you were talking about food, I was reminded of the introduction to the ACEs study, you know, and that was just one group. But you think about all these women losing weight and not being able to keep off the weight. And then it's discovered that there's this history of childhood sexual abuse. And so, you know, you have that woven into it as well. So things are complicated. And I think we do have to have a certain level of humility and a certain degree of gentleness with ourselves. Because us humans, we're complex, you know, and add injury and add unacknowledged injury or not acknowledged on the part of the people who are trying to help us. It just gets, you know, it goes direction that we don't want things to go. So,
well, and there's a problem for Caitlin in this too, as the provider, because you're supposed to show, in order to get a grant, you're supposed to show results. Well, sometimes the results take a whole lot longer, and they don't look like they're good necessarily the first, you know, small period. So just the whole system, we're working, the system itself is in a situation, a perpetrator in a way. So we have to work against the very systems we have to use in order to succeed.
Andy?
I'm thinking about the word leader or leadership and how that applies to self-organizing groups like the Food Policy Council that we're helping to create. If a leader is somebody who asserts power over and is dominating and controlling, that's one model that could be very confusing to step into a group that's trying to use a different way. I don't think I'm articulating this very well. I feel a little stuck, but I hope I'm coming across that some of the work we're trying to do is different from what people have experienced. They've been exposed to different models of leadership. So being aware of that, responding to that situation, and helping to coach people to a different way. I don't know. I'll stop there.
Yeah, Andy, I think that's a great point. And I just want to say, you know, one of the aspects of trauma-informed care that I'm really drawn to is actually what's called like the self-healing communities model, which is really thinking about how do we as groups come together um, and in, and implement and cultivate practices that actually create healing spaces as opposed to just trying to push past that trauma. And so I think there's a lot of potential within the organizing that we're doing now and into the future to really think about how we create healing within that organizing And that's a big part of the reason that I wanted Chase and Rosie and the trauma informed folks to come today. And I just so appreciate this perspective and being able to pull this into our work.
Yeah, I'm. This is a big topic. I think the word circle even is good to reference. I'm going to be in a talking circle later, and it's all about essentially thinking more about how we structure our leadership and what knowledge do we as the people being helped possess, right? And what knowledge do the people who are helping, and maybe they're not in separate groups all the time, and even if they are, maybe there's a lot to tap into. So the mutuality that trauma-informed care offers, even if you think about the question, I know it's a simple question, but what happened to you? You're locating the source of that, the answer to that question in the person who is usually the object of either critique or judgment or assessment. So I think trauma-informed care is much more collaborative in nature. And that's where my head went when I heard your question, Andy, and I heard your response, Caitlin. Does anybody else want to speak to that? Or anything else that you're thinking about?
I apologize for being late, but I know I came with Heather at the end of Heather's explanation of what she experienced in her community. And I just need to clarify, and I apologize again for being late and wanting this clarification. It sounded so much like a drug addiction withdrawal problems, and how oftentimes people use drugs as a way of escaping trauma from childhood or whatever, or just immediate trauma within their life. And I'm just wanting to, is this very similar to like a drug addiction or any kind of addiction? It's like a sugar addiction or addiction to all those chemicals and the processed foods that our body has gotten used to. Is this what I'm hearing correctly? If anyone could help me, and I apologize again for being late.
You're forgiven, Kathleen. You don't have to apologize anymore, okay? I'll grant you that. And that's a good question. Anybody want to respond? Ask a question of clarification?
So I was just waiting to see if anybody else would respond, but yes, it exactly functions the way an addiction functions. And trauma changes the brain in such a way that it requires medication, if not connection. So if you can't make a connection with another human being and downregulate your vagus nerve, basically, you're going to use. I mean, every addiction is a way of changing the brain in order to cope with something that's happened to it. And you know, if you want references, look up Bessel van der Kolk and Gabor Mate. It's pretty. There's people, and Stephen Porges. There are people who'll give you that nuts and bolts explanation, but the answer is yes. That's exactly what it is. And harm reduction is a progressive way of adding connection while reducing the use of the outside tool like sugar or opium or shopping or sex. So it's sort of, you want to go down with one thing and up with the other at the same time instead of something really abrupt.
Yeah, I'm kind of going to a different topic, but thinking about like different issues like organization, community, and what I really have a hard time getting around is once you get to know people and do different types of work or just collaborate, a lot of messy things come up. You know, what's hard is people who we all have had, I think a lot of us had abusive environments with different experiences. The problem is sometimes when people are used to grow in that environment, they perpetuate the same pattern. I think I bring this up a lot of restaurant workers and owners are very abusive, and I think it's actually like a chain. That's the only way they learn how to operate a business, and they just perpetuate the same pattern. And also, like, when you're involved with community projects, with, different, communities, low income, a lot of different trauma, it's, these like conflicts come up. And I realized once I actually started experiencing these things in different community projects, I'm like, oh, not ready to handle this. And I'm a grad student at UMass, and I also try to talk about these things, or just you know interact with other peers and with professors, and there's sort of a typical stereotypical academic disconnect. It's everything is sort of a problem that can be written down and abstracted away with no negative emotions, no real, like, human factors. Everything just numbers and data. And it's like, I think it's almost academics. I don't know if they know these things, or they deliberately want to avoid these by abstracting everything away and hiding these things don't exist. But I don't know. It's just a lot of. I mean, I guess I'm rambling here, but two kind of things that came up that's on my mind, but I can't really get around is, so you got the issues of us people, like, who are traumatized, perpetuating trauma, but also, oftentimes, especially among people of power or people who are more academic than not, there's sort of this disconnect, about these kind of dynamics. There's a disconnect and perpetuation, and I don't know, it's just seems like a very difficult dynamic problem to solve.
It's good. It's good to hear your rambling thoughts, all of you, right? This is just some spices in the stew here that's already on the stove. And you all have been thinking about this, whether you realize it or not, right? Whether or not you had the right language. And so this is in addition. Did you want to add something, Kathleen?
I just totally agree with Nathan. It's an issue that it's so hard to correct because it's really based on the SADS diet, the standard American diet, which is harmful to humans. And it's so sad that our country does not regulate things like, the medic stuff, chemicals, I can't think of the name, I'm sorry, but the bad stuff that's sprayed on stuff in order to preserve them. And the fact that you're eating preservatives and what's that doing to your body and your digestive issue. And yeah, I mean, the SADS diet is perpetrating a lot of these food disorders and the processed foods. But then again, it helped to prevent people from starving to death. So it's a conundrum that should be addressed. And unfortunately, the Congress or whoever it is has also ratified the SADS diet again for another 10 years. So we're fighting against a system that refuses to be educated by the educators, and we are the educators. And it is frustrating. And I'm sorry to vent, but Nathan's right. Sometimes we're on a treadmill, but that doesn't mean we need to stop the treadmill.
Yeah, there's a quote by, I think, Upton Sinclair. And I think this is a huge factor of financialization, or financial incentives. It is difficult to get a man to understand something when his salary depends upon his not understanding it. And we got this huge system. And I mean, related to food is also the lived environment, because we study regional plan. I'm studying regional planning, so I'm looking at different issues like food system, but also how we design our cities and towns to be a lot less walkable, a lot less equitable. But I mean, the system as it works benefits somebody. I mean, that's why it's continuing the way it is. So, and that's another dark and difficult challenge. Once we start talking about these things and bringing changes to our system, somebody is gonna, I mean, somebody is gonna harm for it. Like, if you try to introduce a healthier, diet by changing federal regulation and subsidies so that unhealthy, commodity crops and overproduction of commodity crops stops happening. Like, it's great for a lot of people, but also for certain people who benefit from it, it sucks, right? So, and there's a lot of talk about making the region more walkable and redoing our zoning code, to increase a lot for smaller homes, more affordable homes, more varied homes. But a huge number of the population in this valley, they resisted, they organized against these kind of things. And people have their reasons, but I mean, it's, you know, so I mean, from an equity standpoint, it's, I think I'm gonna stop talking. I guess
Well,
that's-
there's a lot that
Yeah.
needs to be improved. I actually
Yeah.
can't believe that we got to this part of the meeting after 2 hours and we're actually like addressing cost, right? The money, right? I mean, and that's woven into this whole problem. But luckily, even though it looks like there's a blizzard outside, I don't have to worry about everybody getting in their cars and being safe. That's not this kind of training. That's not this kind of day. But we really appreciate all of you for coming and participating and being caring citizens. So if this was good, please say so on the evaluation. And the training has been improved by evaluation feedback. So we really take it to heart. And I want to thank Caitlin for having us come and Chase for facilitating with me and Lori for doing the tech stuff, and wish you all a great afternoon, and stay well, stay well.
Thanks, everyone.
Thanks,
Thank
Chase.
you,
Rosie,
Caitlin. Thank you, Lori. Thank you, Rosie.
Thank you.
Bye, everyone.
Bye, everybody.
Thank you.